Welcome back to another Explainer. Today we're putting on our medical billing detective hats and cracking the case on coding and demographic edit denials. If you've ever stared at a denied claim and thought, why is the system suddenly acting like my diagnosis and procedure codes speak two totally different languages? Well, you're in the right place. We're going to break down the exact strategies an accounts receivable associate uses to solve these mysteries, get the claims corrected, and, most importantly, get them paid.
All right. Let's take a quick look at our blueprint for today's investigation. We'll cover coding and demographic edit denials, dive into root cause analysis, walk through resolution workflows and scenarios, look at a standard AR caller note template, and wrap it all up with a knowledge check.
So, let's jump right into Section 1, Coding and Demographic Edit Denials.
Here's our core hit list of denial codes. I definitely recommend keeping these handy because these are the exact clues you'll encounter when an edit denial stops a claim right in its tracks. Notice CO11, that's the classic diagnosis inconsistent with the procedure error. Then we've got CO58, which tells us the treatment happened in an invalid place of service, or POS. And rounding out the list, we have CO146, 181, and 182. All of these point to codes or modifiers being outright invalid for the specific date of service reported. It's basically the system's way of saying, hey, something here just doesn't belong.
Moving right along to Section 2, Root Cause Analysis.
Think of an unplugged cord. It's the perfect way to represent what happens when a CPT code and an ICD diagnosis code just don't logically connect. The flow of information is completely broken. The payer's system looks at the procedure performed, then looks at the diagnosis provided, and it just cannot bridge that gap between the two based on their clinical rules.
So, what causes these disconnects? Well, they usually stem from a few common culprits. Sometimes it's a simple human typo during charge entry, a slipped finger on the keyboard. Other times it's a technical error, like using outdated CPT or ICD code versions that simply aren't active anymore for that specific date of service. You might also run into an invalid CPT and modifier combination, or a place of service mismatch, like billing an outpatient clinic code for a surgery that actually happened in an inpatient hospital setting. And finally, the system might flag an edit because the codes are inconsistent with the patient's demographics, like billing a maternity code for a male patient. It happens.
All right, Section 3, Resolution Workflows and Scenarios.
Let's compare two distinct paths for fixing a CO11 or a similar inconsistency. For Scenario 1, we look internally. We verify the original charge sheet against what was actually typed into the billing software. If it's just a simple charge entry error, easy. We update the software to match the source ticket and resubmit a corrected claim. It's a really quick fix. But Scenario 2 takes a totally different route. Here, we check the billing history. If we find that a previously paid claim exists for this patient with the exact same CPT, diagnosis, and modifier combination, boom, we have precedent. We get right on the phone with the payer representative, provide that previous claim as proof, and request direct reprocessing of the denied claim without changing a single thing.
Now, what about Scenario 3? This addresses our CO58 denial, the invalid place of service. You definitely don't just guess the right room here. You systematically cross-check the hospital or facility records to verify where the patient actually was. You confirm the appropriate code, for example, updating to POS 21 if it was indeed an inpatient admission. Then you update that place of service directly in the billing system and fire off a corrected claim to the payer, making absolutely sure you do this within their specific timely filing limits.
Scenarios 4 and 5 deal with the heavy clinical lifting. This often involves age and gender inconsistencies or really complex modifier issues. First up, you assign the account to your dedicated coding review team. The coders are going to verify the current guidelines against the actual clinical documentation in the chart. Now here we hit a fork in the road. If the coders find a mistake was made, they provide the correct codes, we update the system, and we submit a corrected claim, usually within a 120-day filing window. But what if the coders confirm the original coding is absolutely 100% correct based on the medical record? We stand our ground, we skip the corrected claim completely, and file a formal appeal, attaching those supporting clinical notes to prove medical necessity to the payer.
Next up is Section 4, the Standard AR Caller Note Template.
I always say, grab your pen, because as the golden rule of revenue cycle management dictates, if it isn't documented in your notes, it simply didn't happen. Your notes are literally the legacy of your investigation, so whatever you do, don't leave your coworkers stuck in a fog with vague updates.
This is the exact template you should be using to document a CPT or POS inconsistency. You capture the date of service, the billed amount, the specific CARC, who you spoke to, and the payer. Then you clearly define the issue. For instance, explicitly stating which CPT code was deemed inconsistent with which diagnosis code. Finally, you document your exact action, like verified in billing system and sent to coding review. And you top it all off with a call reference number. This keeps your notes crisp, professional, and universally understood by any fellow associate who might access that account later down the line.
And finally, Section 5, the knowledge check.
All right, question 1. Think back to our initial blueprint of the denial codes from earlier in the explainer. What specific issue does CARC code 58 indicate? Take just a second to lock in your answer.
If you guessed invalid place of service, you're spot on. This is exactly what happens when you try billing an outpatient facility code when the patient was actually admitted as an inpatient.
Let's move to question 2. You receive a CO11, a diagnosis inconsistent with procedure denial. But you check the billing system and you see previous claims for this patient with this exact CPT and DX combination were already paid by the payer. What's your next step? Think about scenario 2 from our workflow investigation.
Exactly right. You don't just blindly alter the codes. You use that historical payment as leverage. You call the payer representative, point out the previously paid claim, and have them reprocess the current claim directly without needing a time-consuming coding review.
Final question, question 3. After sending an account over for coding review due to an age or gender inconsistency denial, the coding team gets back to you and confirms that the original coding is 100% correct based on the clinical charts. What must you do next? Basically, what happens when the coders tell you they didn't make a mistake?
You skip the corrected claim process entirely and go straight to a formal appeal. You submit the claim alongside the medical records as hard evidence to prove medical necessity and validate that the services rendered actually match the patient's documented condition.
That brings us to the end of our investigation today. I want to leave you with a final thought to ponder next time you're working an account. Are your caller notes solving the mystery for the next associate, or are they just creating a brand new one? Remember, your documentation is the lasting legacy of your hard work. Share and subscribe for free courses on Decode Healthcare with Harshal.